Let me introduce our panel to you. I never thought I'd see this word associated with the New South Wales Treasury, but it's justice. We have Joshua Shrubb here, who's Executive Director of Health and Justice. I suspect what he's talking about is doling out money to justice rather than justice within New South Wales Treasury, but we'll explore that in a moment. Next to Joshua is Phil Harris, Professor Philip Harris, who is the Chair of the Board of Southwest Sydney Local Health District, Professor of Cardiology and Medicine at the University of Sydney. Next to Phil is Paul McClintock. We're very fortunate to have Paul here today. Has a deep and abiding interest, almost career-long interest in federation and the issues around federation. He was Cabinet Secretary. He has been involved in COAG reform at the highest possible level, and now spends a lot of his time in the private sector as Chair of the Board of Myer, and also he's Director of the Board of the George Institute, so has a strong interest in medical research and public health. Next to Paul is Tony Lembke. Tony is a GP from Alstonville in New South Wales. He's the chair, remember those things called Medicare locals? Well, he's chair of one that still exists, North Coast Medicare Local, one of the more innovative Medicare locals in New South Wales. Also director of the Australian Centre for the Medical Home. And this has been a big push in the Australian Medicare Local Alliance and previously the Australian Divisions and Networks, Australian General Practice Network, which is actually encouraging people to have their own GP and for general practice to be the home of healthcare in the primary sector. Next to Tony is Rohan Hammett, who's Deputy Secretary of Strategy and Resources in the New South Wales Ministry of Health. And last, and certainly not least, is Michelle Sharkey, who's Executive Officer of the Stroke Recovery Association in New South Wales. Please welcome our panel. Michelle, you're here to keep the bastards honest. What role do you think consumers should, and this is not a tokenistic question starting with consumers, some people would argue that you're not really going to get reform unless consumers drive it, and the extent to which actually the system provides capacity for consumers to do that.
I think it's absolutely essential that consumers are involved in any discussion about policy and how that is derived. But I also think it's really important that the consumer involvement go all the way down the procedure level as well. So the development of policy, how that is brought into the health system and how it's implemented, even right down to the bedside. And I know patient stories are a really important factor of health discussion and health planning these days. But I think we spend a lot of time looking at the positive health stories of people, and we've got a lot to learn, and I've got a lot of good things to learn from people who don't have such a positive health journey within the system.
But it's more than just stories. I mean, we're talking about sustainability. Mm-hmm. So some people argue, I mean, if you say the Consumers Health Forum argues that you've got to put actually power, you've got to redress the power balance in the system and give consumers more power and address the information asymmetry. So you actually get more of a market going because of that information asymmetry. But other people say, oh, if you put that sort of power in the hand of the consumers, you'll get unlimited demand and costs will go up. How do you respond to that challenge?
I don't actually agree with that, I have to say to you, because I think one of the real important issues of building a sustainable health system is to actually, for the person and the patient and the consumer to work in partnership with the doctor, the nurses, and everyone else. And in order to do that, you need a couple of things. You certainly need a trusting relationship, but you need a level of knowledge. And I think one of the things that have happened in the past are that we work in a system which is very complex. And as a result of that, our knowledge is very complex and often quite precise. But my question would be, are we able to then give that information to the consumer in a way that they're able to understand it? And for somebody to just sit there and nod does not necessarily mean they're understanding what is being said. And often, in terms of ensuring that the partnership progresses and develops really well, you have to completely come back again and again to have the discussions with the consumer again. And I think that's one of the ways that is going to work very well. When the health literacy of consumers increases and the power shift occurs, so that it's not the doctor and the consumer, it's the consumer and the doctor, or the consumer and the nurse. And having been in the health system a number of times over the last 2.5 years, that system hasn't changed that dramatically. It does if you know what you're doing and you can stand up for yourself. But there's an awful lot of people out there who don't know how they can negotiate the treatment they receive. And I think it's easy for us within the health system to take advantage of that and not bring the patient, the consumer, and their family, can I say, along with us in the discussion about how their health is going to develop, how they're going to get well, how they're going to stay well, or even how they're going to deal with the issues of their disability long term, or even the discussion about how they're going to end their life with dignity and grace. And, you know, I think often consumers do put a lot on the medical profession in that regard as well. We expect that they're going to, I guess, ensure that we're given all the information, that they're given all the information that the doctor or the nurse needs to give them. But it's not always that easy to tell people negative information. And that's just the human condition, I think.
So Joshua, from Treasury point of view, and you live in the world of economists and policymakers at the Treasury level, what's your reflection on that discussion in terms of, if you like, the marketplace driving demand and that creating sustainability or creating risk? Presumably it would be music to the economist's ears to say that you'd create more of a real market in healthcare.
A sustainable system, I think, is one where one that's providing the healthcare that people need at a price that they're willing to pay. And at the moment, it's very difficult to get a grasp on that willingness to pay side of that conversation. And I think that leads to this.
So you're a co-payment fan then, are you?
It's not. You can have price signals that are not actually charging somebody. I mean, activity-based funding sends price signals within a system.
Doesn't send any to patients, though.
There are also price signals that you can send simply by telling people the cost of their care has an effect, even if you're not charging them things. And of course, there are many parts of the system where people already do pay at least part of the cost. At the moment, it's very difficult for any average person to understand what actually is the cost of their health care. They're paying some fees and charges, they're paying federal taxes and state taxes, they may be paying insurance, their insurer may be paying insurance. There's a serious information gap there, and that, I think, transparency and better information around the cost side, as well as better information about the care itself and what are the options available to them and so on. I think that dialogue is really important, and greater transparency around that will enable people to have a better view of what are the decisions that they want to make.
But what's the Treasury view of waste? At least 150 interventions that occur partly in general practice, partly in hospital, are considered low value. In other words, they don't get us anywhere. Waste of time and money. There's adverse events. There's all sorts of things that go on in the system that if consumers knew, they might be a partner in waste reduction.
Absolutely.
What's the Treasury view of that?
I would say first the Treasury view is we're not the experts on the technicalities of healthcare, and we shouldn't pretend to be.
Yeah, but you sit in meetings and bully the health department.
Our job, I think, is about setting the incentives and the systems and structures that will drive those behaviours through the system. I think there is a place in that for contestability, both within the system and between the public and other systems.
Sorry, contestability. Just play that out for me a minute.
Again, there are we have a mixed system at the moment. We have private provision, we have public provision, we have increasingly we're looking at innovative arrangements where there is public purchase of things from
like
private providers, like Northern Beaches. Those things create choices and options and pressures within the system for people to optimise their efficiency. Transparency, I think, is a key part of that agenda as well, about not only about the cost, but about the outcomes and what's being achieved, because people need to be able to make those judgments about value. And I think most of the evidence is that contrary to what people sometimes think, that efficiency and quality are opposed, a lot of the evidence is actually that efficient care is quality care, and getting these things right actually goes together. It's a single agenda.
Paul McClintock, let's just pull back the lens for a moment and look at federalism and what you think are the opportunities at the moment, given that there's clearly a new conversation going on with federalism.
Well, I was very encouraged, Norman, by listening this morning because the last time Norman and I got together was at a George Institute breakfast for World Health Day, and I said, and he asked, where are the disruptors that are coming in that will significantly change, or where there's an opportunity to change? And I said the combination, and they were both federal issues actually, the combination of the fiscal situation in that our ability to fund indefinitely increases is clearly stopped, and there is an understanding, not so much in the community yet, but certainly amongst the political class, that the assumption that you can continue to do 5%, 6% and 7% indefinitely just isn't there. And secondly, there is a commitment by the new federal government to have a serious run at looking at how the federal system works. And the fact that Mary and Christine both focused on that as a significant sort of next issue in health reform, I think that was really very encouraging. I told them both I thought that was a really good sign.
So what's the opportunity, given that conversation will go on for some years, this sort of coag pace, what is the opportunity, where's the blue sky and the clouds for the state government or state system to jump through in the interim?
Well, I think that the state government is doing absolutely everything in the interim that it should. I mean, I thought the minister's speech was very good in relation to the fact that there are a number of areas such as keeping the best national partnerships going and so on. That's what you should do. And what everybody in this room is doing. I think the people in the room are the problem, to be honest, because they're doing too well. And if there was a burning crisis and everybody saw that there was an immediate problem, maybe there'd be more speed in this process. But in fact...
Are you suggesting a Trotskyist revolution in this room?
No, I just think... I think the system is running well, and it's running well, as was said in all the speeches this morning, because of people in the room who are making it work well. There is still enough buoyancy. We were really lucky with property booms and things in Sydney to actually give a state government that had the ability to do some things, but it isn't sustainable. And if it's not sustainable in New South Wales, I can assure you in other states it's absolutely not sustainable. So I don't think we've got years and years to do this. I think the review of the federal system is actually due to take place in this term of Parliament. So we are looking at a white paper that is not years and years away. Rolling it out is years away. But as you know, I was also very pleased to see Christine Bennett remind us that Medicare Select is still out there as a sort of long-term possible model, and that would maybe take 15 or 20 years to do. But
so
that
just to
doesn't
remind
stop
people,
you.
that's a contestable environment for health insurance.
Yes, it's essentially it's the ultimate go at coordinated care, which has also been talked about a lot this morning. You put all the money together, but you actually have a contestable, so people have to compete to have the right to actually be your person. And that's where the Bennett Commission ultimately ended up as a possible, they didn't say it should happen, but they said it's a sort of idea that you really start to think about if the sort of things that Mary and Christine were talking about this morning are right, and that coordinated care outside the state system, a national coordinated care system, is the key to a sustainable system, then you've got to start to go and think about those sorts of things.
Phil Harris, what do you think are the key enablers for health system sustainability at a district level?
I think the most important one, and many of them have been touched on this morning, but the most important one is shared information. I think that all the care providers across the district, across the local communities, have to be sharing the same information about the patient. It would also help a lot if we were able to advance those systems to, I guess, the state that exists in Canterbury in New Zealand, where there is even a single electronic appointment system. So that's important, the information systems. Clearly, the communication and the communication between the primary care providers, the NGOs, other accredited organisations, and the LHD is just absolutely essential. And the patients and the consumers need to be part of those communication links. And I think...
In what way?
Well, the consumers and patients need to be part of the planning right up there, and they need to be, I think, involved in, particularly in areas which is, palliative care, end-of-life planning is critical to have patient input, consumer input. And even, I think there is a growing body of evidence that even in the provision of care, that high levels of patient satisfaction are related to good quality of outcomes. And it's as a doctor, it's a new dimension of thinking that we've always thought that good survival, low complications are how we measure quality, and we have to adjust our thinking that now how the patients and their carers perceive our care is another dimension of quality that we need to strive for.
But Phil, we could have had this conversation 10 years ago and it would have been the same conversation. What's different now, if anything? You've said all the things that we've been saying for 20 years.
I'm not. Well, I think the one thing that's different now is the evidence base for what I'm saying. That there is now good data to back what were 10 years ago, sort of hunches, if you like, or was preliminary. So there's very good data to back it. And I think that particularly in New South Wales, the Garling report has changed the way we do things. And I think, and Mary mentioned it this morning, I think there is now much greater clinician and the devolution process has allowed much greater clinician and consumer engagement in the process. So the reforms that have gone on in the devolution has allowed what were just thoughts 10 years ago to be put into practice and put into reality.
Tony, I mean, everybody's looking to general practice to save the hospital system.
Norman, I note that I was looking at the figures when the recent discussions came out about the co-payment and doctor fees. And if we're talking about sustainability, I worked out that based on the Productivity Commission papers that for the price of one admission to hospital is the same as the average spend of 15 years of general practice services for the patient. And that is cheaper. It's cheaper for someone, and I just checked this with Joshua, it's cheaper for someone to see their GP every week for a whole year than it is for them to spend one day in hospital. So to try and discourage people from seeing their general practitioner is exactly the wrong way of making a sustainable health system. But the needs of the consumer, it's interesting in the health plan that Rohan's learning off by heart here.
He's going to be examined on it in a moment.
The needs of the consumer, or the wants of the consumer, and the health plan aim are exactly the same, which is to keep people healthy and out of hospital. So I don't think we need to be scared of, the consumers driving it. They don't want to go to hospital. They want to remain healthy and in their own homes. And so, we're faced with the chronic disease tsunami. Look up, I'm from Byron Bay, and up there they say, look, you can't stop the waves, so you better learn to surf. And faced with the chronic disease wave, we actually know how to surf. The evidence is that chronic disease is better managed by better systems for delivery of primary care. And the real work in chronic disease is done in people's homes. And so, faced with that, the investments and the focus needs to be made in building a health system where people can receive the care they need in their communities, best off partnering with a particular practitioner, a particular GP, wrapped in a practice team that can provide a range of service with the health of the system, the rest of the health system recognising that partnership and wrapping around it. And then we'll get, I was very happy to hear that the Minister and Dr Foley talk about their aim for integrated care, because you learn to surf by realising that it's a team sport. Well, surfing's not a team sport, so that doesn't work. Chronic disease management's a team sport.
I think we've generally accepted there's a limit to your metaphor, but we kind of get it. But how do you create an incentive for that kind of practice, in general practice? I mean, it's the figures for. I was gobsmacked the other week when I discovered how low the rate of practitioners applying for practice incentive payments is. It's not 100%. I mean, it's not even 80%. So a lot of doctors are not going through the sort of process, even with a very significant incentive that could give them tens of thousands of dollars into their practice. They're not applying for it, which would improve their care and actually provide the sort of care that you're wanting to get. People are it's the corporates who are actually claiming highly on the enhanced patient care items, not necessarily individual general practitioners. Then the individual GPs get frustrated because there are not the payments available because they haven't thought to actually get into this coordinated care. The level of GP engagement at Medicare local level, which was one of the sources of criticism, was low, and you had variable, I should say, around the country. So the question is, you're making a big pitch for general practice. There's a lot of people out here who are frustrated with the ability to engage with general practice and get the sort of service that you provide in your practice, and they're provided in some other of the practices on the North Coast, but not all.
So thanks, Norman. There's some key points there. You're quite right. I think recognising and supporting quality practice is one of the greatest challenges for the profession, that we can decide upon what makes a quality practice and then put in the incentives where the community benefits lie. And the current system, based as it is on a $36.30 fee-for-service payment, does that fairly poorly. But I don't think we should focus all the time on the lowest. When my kids went to school, the headmaster at the first address said, "Look, listen, if you only believe a third of what the kids tell you happened at school, we promise to only believe a third of what they told you happened at home." and I think we often focus on the lowest common denominator general practice. In A&E, they're always telling us about the ones who do it really poorly, and I can tell you about the hospitals that do communication really poorly, when in fact most of the time it's done very well. And we don't want to focus on the lowest common denominator as if it's the norm, because I don't believe it is.
But my fundamental point is, if the state government, and they are, I mean, they're working on Care Connect and so on, I mean, some remarkable results in various health districts in terms of people with really right at the extreme end of chronic illness. But what would the incentives be for general practice from a state government working in partnership with them, which would move the bell curve to the right?
So there are models of care that we've seen work very successful to support those high, the 1 or 2% of high frequent flyer hospital admissions, and the CVC, the Veterans Affairs, provide a good model for that, whereby they identify patients that they want extra care provided in general practice, including care coordination, practice nurse visits, practice phone calling, telemonitoring, and they pay the practices a premium to look after this select group of patients. And it would be cheaper for the health service to pay these premiums for those that they select for general practice to manage using ways that aren't supported by the current fee-for-service, then it's significantly cheaper for them to end up in hospital. So there are different models of care that support the non-fee-for-service basis, but there are many, many practices working in the current system that are keeping their patients well and out of hospital, using care planning item numbers and chronic disease management item numbers, using practice nurses at the top level of their skill set, doing care coordination, and doing it because they know that they aspire to give their patients the best care they can, so that it happens all over the place and all over the country. The systems could support it to happen everywhere if we redesign them appropriately. And I did notice the Federal Health Minister in the budget said that the PIP payment that you mentioned will become a quality payment. So most of the jurisdictions around the world that do it well have a mixed fee-for-service and quality payment aspect to the way general practice is funded. We have no details on what he means by that, but one might be hopeful that we'll start to see quality being appropriately rewarded and valued and supported.
So Rohan, you're rolling the dice on integration. I know tomorrow is a big discussion on integration, but you are rolling the dice on integration. What should it really look like? Given that you do have a fragmented system, good variable quality everywhere down the line, is it all just about pathways?
Norman, I think the answer to that is probably best answered by all of you sitting here in the room. What do you want your healthcare system to look like for you as an individual, for your family when they require it, when your kids need help or your ageing parents need help or you have an accident? Ideally, we want a system that connects, that is seamless in the way that information flows between the GP who you see on a regular basis or an irregular basis, the hospital that you might need in an emergency, the pathology and radiology and allied health providers that might provide tests for you. And you want to make sure that the necessary information to provide the best possible care for you flows seamlessly. I think, you know, it's not going to be that long, Norman, before you and I are lounging on the veranda of the nursing home reminiscing about the 19th of June and reflecting on perhaps the early part of the 21st century as the start of the age of enlightenment in healthcare, where information was moved out of the cloisters of the specialties and the ministries of health around the world, and information became available to the people, both the consumers and the clinicians, to guide what should be the right sort of healthcare. So just as Western civilization progressed when knowledge came out of the cloisters and the Dark Ages ended, well, in case anyone hadn't noticed, Dr. Google has arrived. There is healthcare information out there that has never been there in the history of humankind, and it will fundamentally change the dynamics of the way healthcare is delivered in the 21st century. Consumers won't be people who are just invited to help us plan services. Consumers will be informed, empowered, and making decisions about what is the right sort of healthcare for them. And we'll be supporting that through things like patient-reported outcome measures, through decision support programs, through real-time patient feedback in our hospital systems, through the linking up of HealthyNet and the personally controlled electronic health record that can ensure that we don't see duplication of tests in primary care and hospital care. So that information flow, that ability to really join up around the needs of the patient, not around the needs of the system, not around the needs of the providers, not around the needs of the ministry or the LHD or Treasury, around the needs of the patient. And that's fundamentally what we're rolling the dice on. And we're doing it in a way that says, well, the answers don't rest in the minds of people designing policy in the ministry. The answers rest with all of you who are delivering services on the ground, because there's nothing surer than the fact that neither a federal budget or a state budget can do what you can do on the ground on a daily basis in terms of the care that you deliver. So fundamentally, integration and how it works will depend on what the people in the system are willing to do and partner on, and us providing the right supportive environment to enable that to occur.
Paul McClintock, do you think you've got the right environment to enable that?
I think we have the right environment in terms of people's commitment and interest to do it at the local level. The difficulty is that too many of the levers for change are still not able to be coordinated. So there's a huge amount of talent. Every time you go in, I've been involved in a lot of health businesses over the years, and full of talent, full of very bright people. They all know this issue. They all know what they want to do. The fact that there is a level of frustration because walls are hit far too often and far too early is an indication that that we have a long way to go before we can really say that there is a smooth ability for then. I think it's absolutely right. The system won't deliver this. The system can only facilitate it. It's the individuals at the front line who will actually then take advantage of the new opportunities. We have a way to go, I think, in giving them the opportunity to do that.
So how best to utilise the private sector? Because in a sense it's a parallel process. It comes together sometimes, in some cases, in cancer care with multidisciplinary based care, but really it's a parallel world with its own drivers. But it's obviously there to be utilised in partnership, if you could.
Absolutely. I think that's one of the strangest fault lines, actually. The culture that has been built up, and I say this with all respect given where I am, in the public system, and undoubtedly you could make the same comment in the private system, is vastly more siloed and inward-looking than you would expect. And of course, most of the system is private sector. I mean, GPs are overwhelmingly private sector. They're individual businessmen. They might be small ones. It doesn't matter. When you actually look at how the system works, most of the services are actually delivered by people who are not employed by government. And yet, I noticed even in the Bennett Commission work, they found it very difficult to break out of the fact that they were solving the problems of the public system. They weren't thinking holistically about the entire system.
Phil Harris, you've struggled with this your entire career, not just when you've entered more the governance role, where it's not infrequent that you hear stories of honorees, VMOs, who come into the system and because they're in a well-governed system behave in an evidence-based way, but you know what they're doing out there. They're putting in 8 stents at a time and doing stuff they shouldn't be doing. And also there's a distortion of access. How to get that shift where you utilise the private system more effectively for the benefit of patients who are coming in through all sorts of gates into the system?
I'm not certain I accept the basic premise of your question, but...
32 cents was the maximum I ever heard, by the way. And we're certainly facing it in southwest Sydney because where we've got heavy demand for surgeries like ophthalmology, ENT surgery, and we are in discussion with the practitioners in that area about how we can best come to arrangements that probably will involve utilising in some way the private sector in order to achieve the outcomes for those patients. To answer... But that's kind of a contracting thing probably rather than an integrating thing, isn't it?
I'm not certain that I understand the difference. I mean, yes,
ultimately... We'll say we've got 2,000 patients needing cataracts done. We'll commission a group of private ophthalmologists to crunch through them.
Yeah, that unfortunately is what the private sector and the public and the sort of discordance between the two does throw up, that we have patients who are entitled to seek their care or their procedures in a private hospital system, and there's a group of people that at the moment are ineligible to seek them in the private health system. And I think our job at the LHD level is to try to find the way where we can take the best of the private system and allow that to improve the care of the patients in the public system.
So, but if you're talking about people with chronic complex illness, which is the people that Tony was talking about a moment, and really we're all talking about in today's discussion rather than necessarily people just need cataracts, the private practitioner, the private endocrinologist, the private cardiologist does not work in a team. They work by themselves. What incentives can you provide the private sector to come into team-based care to actually get the best possible outcome? I mean, arguably, you can say you get better outcomes in the public sector than you do in the private sector because there is more team-based care. Yeah.
Well, I'd like to start back at the premise of your question, which I said was false. I think within, and this is heresy, but within our system, we need to swing across from the incentives for doing procedures, if you like, providing services, through to change it to incentives to providing care. Now, I believe that it's not just that we want the cardiologists working in teams, we want the cardiologist working in a team with the endocrinologist, with the respiratory physician, with the aged care specialist, and probably with the gastroenterologist as well. And I believe this...
Tony's making a bid for the GP to do the lot.
No. Well, but that's the very point. I think that it needs to be close, physically and geographically close, even in the same building with the GP, and I have to say, building around it your allied health services and other services that are required, and certainly that's the way we're thinking about service delivery in the Southwest in the future.
So Michelle, what does the consumer need? If you take Rohan's vision, but also the fragmentation we've just been discussing with Paul and Phil, what does the consumer actually need to play that role to drive that change at a local level that they don't have now?
I think they need a couple of things, but I certainly think that they do need the access to be able to actually drive it as well. Like, they need to be able to sit down with that whole process right from the sharp end right through to what I call the blunt end. So unless there's connection right all the way through, then they're not going to get the quality of care. So you can go and see your cardiologist or your ophthalmologist, and you can go and see them in a private setting, but sometimes when you go home and you're an 86-year-old who's just had your cataracts off, you actually need somebody to come in every 2 days to put the drops in, and that's not always available. Or if you have a sort of ongoing chronic care and you are living on your own, you need a process whereby all of those people who are dealing with your chronic care speak about your particular case, and somebody follows up. And I think we can have as many sort of policies and procedures as we like, but unless there's some process right at the coalface where the consumer is absolutely sure that they're going to get the follow-up and the quality of care that they're going to need in order to provide themselves. Because I think one of the important things to remember here is that you don't own my health care, I actually do. And when it comes to which doctor I see and what advice I take, I will make that. And I think that's becoming an even bigger thing. And with this situation of mine at the moment, I actually interviewed a doctor about who was going to do my second lot of surgery. My son was totally mortified. He said, "You were so rude, Mum. You had no right to speak to him like that. How dare you?" I said, "Yeah, that's okay, Lachlan, but he and I both know he will never do my surgery now." Okay, that was what it was about. It was about working out whether this man had the capacity to work with me to develop a plan for my health. And I think we need more consumers too to be able to stand up and say, "No, your service isn't good enough. I'm paying you, and I'm paying everybody in this room, I have to say to you, which is great." And that, I'm not saying New South Wales Health doesn't do a great service, because I think it does. But I think what the consumer has to do is really move out of that almost victim behaviour into that, as I said, partnership role. That, it's about you working with me so that together we can have the best outcome for me. And long term, I will drive my health care. But I do need your expertise to guide me on that, which is really important. And can I pick up another point that was said earlier in terms of the whole thing that's what's happened in 20 years? Well, what has happened in 20 years is that New South Wales has engaged consumers. Okay, maybe not as good as they should or whatever, but I actually think they've done an exceptionally good job on it. And I also have to say to you that every change that comes about is a slow process, and particularly with New South Wales Health. So we're dealing with a very complex system, but we are changing it. And I think the more consumers get involved, the less fearful allied health clinicians are of the input of consumers, the better off the whole process is going to be, and the more sustainable,
So,
Norman, can I have a go at, because I'm sure you don't want to just straight jacket at answering your questions.
Sure.
To do it, you've got to invest in case management. You've really got to have people who can, because most of us don't need case management, obviously, but when you become very seriously ill with very complex issues and large teams of people, to expect, we sort of expect the GP to do that. And I've watched. I have a brother-in-law in the last stages of his life, and he has a GP. It's in a large clinic. They don't do house visits, so here he is at home. His case manager is completely inaccessible, and you can't do this unless you put dedicated resources who have got the job of representing the interface between the patient who is actually doing what you were talking about, of actually exercising their discretion, but then they need some sort of help to interface with the complex people that are actually doing the job.
Joshua? What's the role for Treasury in all this? Can you create new incentives? Can you force the issue? I mean, presumably you'd quite like an increased consumer population with the sort of attitudes of Michelle.
Yeah, I mean, I think that the patient is, where possible, the best person to have that power. It is their care, but they are not going to be the experts. They need help on this. So I don't think there's a simple one-size-fits-all solution to this.
But you just heard Paul saying, and most people in the audience would recognise that Paul was absolutely on the money about case management when you've got a complex problem.
Yep.
Surely...
So part of the problem that we have...
You're not a passive funder.
No, not passive. But part of the problem we have at the moment is we're only one of the funders. We have a very, we don't have a health system. We have multiple health systems here. We have, Commonwealth is a funder. The state is a funder. The Commonwealth funds the state to fund. That it's a very complex mix. And while at the front line, there's generally very strong desire of people out there to actually work together and
This sounds like throat clearing for helplessness here.
It's a recognition that we have at the moment, and the Commonwealth budget's really brought on an opportunity for a discussion about how that works. And what we have at the moment has, I think, despite the best will in the world at the front line, there are different incentives for different players, particularly as you get away from that front line. And we have an opportunity to rethink that and how to restructure some of those incentives so that they do work to support the sort of things that these people are talking about.
Rohan?
I want to jump to the defence of my Treasury colleagues who,
in
case no one had noticed, had actually...
it's not going to do you any good at all, Rohan.
Had actually done a very good job of delivering a state health budget that has, if you consider the $220 million that we've had to make up for NPAs, it's a 7.1% growth, which is quite extraordinary.
But hold on, so you're thanking them for the 7%. Big deal.
I won't give them a free ride completely. So one of the things that we've been working together with Treasury on is to get an understanding of how we can more intelligently use the transparency of our current funding models and purchasing models to ensure we're buying the right things from our healthcare system. So we are investing in integrated care. We are saying there is value to the consumer in trying to join up parts of the system, and we're going to use parts of our budget to do that. And we're talking with Treasury about the fact that we know what the population growth needs would project our activity requirements will be within our hospitals. We also know that there are areas of activity within our hospitals that aren't as efficient and effective as they could be, and we're working to correct those. We're enlisting in a conversation with central agencies, treasuries, and indeed, hopefully with the Commonwealth, rational decisions about what they will purchase from the health system, acknowledging that the health system is something that we all need. It's an entitlement system. What we have to do is make sure we're purchasing the best value money for services.
At a Miller Street level, assuming we have, how many primary health networks we're going to have in New South Wales? 4? Tony, do we know yet? We don't know.
We're going to have 15
17,
if we get our way.
You're going to have 15.
Somewhere between 15 and 1.
Go on, just feel the blood on the floor.
Commonwealth reps in the room, 15 is the number, lining up with our LHDs exactly.
So the question is, it's very variable at the moment, the extent to which Medicare locals have a true window into the local health districts in terms of that negotiation that you just talked about. So that's a conversation that happens between you, between Treasury, and at district level. So the extent to which you're actually willing to open that up significantly to these new primary care networks so that you actually can have an integrated incentive discussion, for example.
I mean, it's changed. Sitting around the table over the last 2 years has been an enormous change in the way that the local health networks have engaged with the primary health space through Medicare locals. And speaking from the two that we cover, Stuart and Chris and the team, that it's just a changed conversation about integrated care. So we're really pleased to see that. And given the example where the general practice, which should have been doing home visits, wasn't, the answer is to try and build up capacity within that general practice so that it can fill its roles as a medical home. And if the practice can't, then we need to start from where we are and invest in home nursing or whatever else is required until that capacity is built. So if we always think about, instead of when the local health network's investing, it thinks about investing in a system rather than investing in a service. How can we improve that?
But it requires the system to listen so that they know that particular corporate's not doing its job, if it was a corporate.
Well, the conversations we have are about co-locating local health network staff in general practice, about paying practice nurses from general practice to do some community nurse work, getting community nurses linked as they used to be to a general practice so that they're working together, sharing records and notes so there's informational consistency, GP inreach into hospitals so GPs know what's happening while their patients are in there, and importantly, most importantly, changing the culture of clinicians. So it's clinician-led, so that this is the way we do it here in Mid-North Coast, this is the way we do it here in North Coast. We demand and expect the best from each other as clinicians. So if poor referral comes in, we'll ring and say that we don't have the information we need. And if hospital doesn't give us the information they need to discharge, clinicians' responsibility to ring and demand the best. So that's that. Designing it so that you're not building services, you're working at the system is happening, and changing the culture of clinicians such that they're demanding the best from each other around the patient is happening. And it's really exciting because I've been at the division for 10 years and now Medicare local couple, and the seat we now have at the table with and I think the direction is coming from Miller Street and from the ministry about integrated care, and they've put real funds behind it. It's an exciting spot, and it would be a real pity to lose some of the momentum that's already been achieved in New South Wales.
You've been very quiet as an audience, because I'm sure we're not necessarily hitting the marks from your point of view. So we've got a few minutes left in this discussion, so please choose the opportunity to come up and throw a few grenades.
Norman, can I say, I think, although it's on a small scale, I think there's a very well-functioning model of integrated care, and that's through the heart failure nurses program that was funded some time ago, and it's one of the most satisfying things that I see, where you've got this sick group of patients with again an evidence base that they can be kept out of hospital by nurses' care or by nursing case management within their homes. And although there's no recipe written for it, in the group that I work with, I see them caring for the patients, but I see them moving the patients between the GP and the specialist as is appropriate.
So they're becoming the case manager.
They are case managers. That's what they're called. Yeah, they're case managers, and I know that if I get a tap on the shoulder that you have to see Mr. X today, then I have to see Mr. X today. Otherwise, Mr. X is going to be in the emergency department. But equally, I get the message sometimes that I've seen patient Y and I've spoken to their GP and he's initiated this or she's initiated that, and so I think that's a system that we need to grow on and expand with this sick group of patients that are using our system.
So you started off today talking about information systems and the need for information.
Yep.
And people are going to be knocking at Joshua's door saying, we want to spend money on home monitoring, wired scales for people with heart failure so we can actually detect what their weight is every morning, automated phone systems, etc., etc. Is there a shred of evidence that they can replace the heart failure nurse, the case manager? Because that's what the Treasury is going to ask. What's the cost offset?
Yes, there is. The trials are being done at this very moment, and one of the remote monitoring processes is in patients. It's not heart failure strictly speaking, but it's in patients with defibrillators, and they compared the home monitoring of patients, because you can monitor a defibrillator from a patient's home now versus clinic visits to monitor the defibrillator, and the patients with the home monitoring had better outcomes. But I don't. It's not going to.
That's a much simpler story than somebody with 4 different diagnoses.
Oh yeah,
that you're managing
sure.
at the
But
same
we're
time.
at early days. But they're not. These devices are not going to replace the nurse. They're going to extend the nurse's role, extend the number of patients the nurse can care for.
Just towards the end of our discussion, we've been focusing on, sustainability of our health system, but also on keeping people well. And prevention is always better for care than curing any illness. There's been no discussion about how we're going to have a system that integrates the whole of government in delivering messages and activities and decisions about how we stop people getting sick and we keep them well.
So I might go to Joshua on that. I mean, the Rob Moody, who was the chair of the National Health Preventive Task Force, argued that since there's no waiting list for prevention, there's no political drive. But are you open to a discussion about prevention, even though the benefits might be 20 years from now?
Certainly open to the discussion, and the discussions are happening. There is obviously a challenge of the timing of investing in things, and that's not just in health but in other areas as well. You have this issue of investment now that delivers benefits in 10 or 20 or more years down the track, and that is a challenge that has to be managed. I think we also have to be realistic about investment in prevention, that sometimes it is actually not the most cost-effective way of doing it. It depends on what is the cost of the early intervention versus the cost of the later, what is the likelihood of the people in the early intervention cohort actually getting a problem later. And of course there are, it's not just about the money, it's about the broader economic and welfare benefits. So for different things, there are going to be different points along the spectrum that are actually the best place to invest, and that's absolutely a discussion that we're keen to continue having.
Yes, Brian.
Yes, thank you. And just a caveat to start with, that I think there are a lot of great things that are going on and initiatives, so I'll put that up front first. But
now you're going to shaft us, are you?
Yes, that's exactly right. This is health system sustainability, and I remember way back someone called Dr. Milton Roma said that doctors determine 90% of healthcare costs, and he used the word determine because it was their decisions that determined how health was spent. And I guess if we very superficially looked at where that was, it would be intensivists, oncologists, orthopaedic surgeons, cardiologists, not to leave Phil out of it, those group of people. What concerns me about these meetings is there are very few of those people here, and we, to some extent, preach to the converted. I don't think there's anything what he said.
But the people in this room can create the incentives and disincentives and manipulate the market.
But unless you can bring, it was Brian McCaughan that said most of the doctors are out there doing what they've done, oblivious to the reforms that are going on, even cynical about it to some extent. And what I'm saying is, how do we change the dynamics? So meetings like this, we've got key clinical leaders in here to take them with us on this discussion.
So I might ask a non-clinical person, Paul McClintock, you sit on the board of a radiology company, and for example, chair board?
I do, and I guess I sit on the board of St Vincent's as well, so I've got a hospital hat on. The communicating to the decision makers is a huge issue in this business, and the only thing I've learned being a non-clinical person, I said I was underqualified for this panel because they're all doctors and professors and things, but there's a couple of us that are not. But you've got to do it through the doctors themselves, that you've got to have strong structures. I know in the hospital businesses I've been in, management telling doctors what to do in this area doesn't work. You've basically got to have very strong clinical structures. The clinicians have got to buy into the message, and then they are the ones that communicate to their colleagues. And the colleagues are willing to listen more than a lot of people think, willing to listen to well-developed issues around efficiency if it comes from a body of fellow clinicians that they respect.
Thanks very much. And final question.
I just got in time. Brad Frankham, I'm an LHD South Western Sydney board member. It just strikes me we're having a very middle-class discussion about health here, about patients entering data into a computer so their doctor can give them remote advice, and going to their general practice who will look after their integrated care to keep them out of hospital. But where I work in Campbelltown, there are an awful lot of people where that just doesn't apply, and I think we should be spending a lot more time talking about the fringe dwellers who actually are the ones who consistently miss out on good care because they don't have access to specialists, because there's no public specialist working in the area, or they have to pay to get their kid to see an orthopaedic surgeon, or they have to travel to the centre of Sydney to get their eyes looked at. I think whilst we've done lots of great things, and I'm not meaning to be overly critical, we really haven't taken everybody with us in this sustainability and reform discussion. So I'd ask the panel, do we think we're moving towards a more equitable system quickly enough?
Well, I'm actually going to ask you, Brad, because you've been working, South West Sydney for a long, long time, and I wouldn't call people, it's a disadvantaged group.
Yeah.
What would you do?
Well, I wouldn't bring in a Medicare co-payment, that's the first thing, but I know that's not a state government decision. That's going to frighten more people away from attending their
let's
GP,
assume
their AMS.
let's assume it doesn't get through the Senate, as it's unlikely to. There's a good chance it won't. So,
yes. Well, I would like to see the state government moving a little more into primary care, actually, and so setting up integrated health centres where people can access them. I think we're trying to look at that. So, but it means that we've got to bring specialists and general practitioners and nurses and allied much better together than they're doing at the moment.
So what incentives would you provide to, my favourite example is not in New South Wales, it's Hervey Bay. People who need a cataract done in the public system in Hervey Bay in Queensland have to go to Brisbane. And there are 5 ophthalmologists in Hervey Bay, but none will see a public patient. So how do you then bring the private physicians and surgeons into the fold when they don't need the public system?
Well, I don't know that financial incentives are going to work because they can make more money in private practice. So this is something we grapple with greatly. A bunch of us in South Western Sydney, we go and work in the Aboriginal Medical Service, but I don't know quite how you bring more people into that system. And you're certainly not going to do it by paying them privately. So perhaps the LHDs need to lead the way in better moving their specialists out to the community. In fact, employing staff specialists who don't just work in a clinic in a public hospital, but who go out to a community setting to do part of their work. And that might mean expanding the specialist workforce. I can't believe we talk about having an oversupply of young doctors when we can't fill positions still in rural and outer metropolitan areas. The reason is we're not being creative enough in the way we think about employing people. This is one of the big opportunities I don't think we've grasped as well as we should.
See, I don't need to go to the panel at all. Brad, thanks very much indeed. We're out of time in this part of the session. Can you please join me in thanking our really terrific panel?